Good morning. Again, I'm going to be speaking about pulmonary emboli. And I approach this lecture through the perspective of someone who's going to be attending in 6 clinical weeks from now. And so I really set out to answer 2 questions as I was exploring this topic. The first is, who do I call IR for? This is a topic that I'm not really sure who I'm supposed to be calling. And what's the best way to manage a submassive PE? And I'm going to preempt this lecture with, there are no answers to these questions. Definitively, there's no consensus, there's no guideline from any sort of academic body. But I did find a lot of interesting topics through this, and I did a pretty deep dive into the literature, kind of soup to nuts about pulmonary emboli, and I pulled out a handful of topics that I think are pretty interesting for us to discuss today. The outline for today that we're going to go through are the classification, that should be 2 separate bullets. The classification of pulmonary emboli, echocardiography in PE. I took out nitric oxide for submassive PE for the sake of time, thrombolytics for submassive PE, ECMO, the 2021 chest guidelines, catheter-directed thrombolysis, and catheter-directed embolectomy. All right. So we'll start with classification. When I was in med school, I learned some sort of a classification like this that I think many of us learned as well. Risk stratifying low risk, intermediate risk, or high risk, the massive and submassive categories. The low risk people are the folks that are normotensive and have any signs or symptoms of RV dysfunction. These are the people that largely can go home straight from the ED, as long as they can take care of themselves, they have access to anticoagulation. The massive PE is the hemodynamically unstable, precipitously dying in front of you patient. They are hypotensive with defined as either like a systolic less than 90 or greater than equal than 40 drop from their baseline, or they are pulseless, they're being coded for a PE, and then some type of bradycardic parameter, profound bradycardia, what this one did. And then everything else in the middle was submassive. This huge group of people who are normotensive, but have basically any other signs and symptoms of RV dysfunction. So historically, this is what we used. And sort of in the last couple of years, there's been a push to risk stratify a touch better, to sort of suss out these middle intermediate folks a little bit better, because this is where the crux of the art of medicine really comes in managing these people. So they're under these new classifications, they've sort of gotten rid of the submassive and massive and use high, intermediate, and low risk, and then subdivide intermediate into high and low risk within there. And it starts first very broadly with this: is this patient in shock? If they're in shock, they're or hypotension, this is a high risk PE. If they don't, then they're somewhere in the intermediate or low risk category. And from there, you calculate a PESI score, the PE severity index. If they are greater than 1 in the simplified newer version, or greater than class 3 to 5 on the old, then they get put into this intermediate risk. And then from there, you subdivide the intermediate risks by the RV dysfunction stuff that we learned as submassives. You're looking for signs of RV dysfunction, things like heart strain on the echo, reflux of contrast, into the liver on your CTA, echocardiographic signs, your McConnell sign, interventricular septal bowing, D sign, and then your cardiac biomarkers, proBNP and trope. If they have both a sign of RV dysfunction and a chemical biomarker, they're in the intermediate high. If they only have one of the two, then they're in the intermediate low. Sorry. And I didn't dive too deep into why this is important historically, but where it is important is sort of in more recent guidelines and more recent updates, that this is how we are going to be classifying patients for guiding treatment. And so it's important just to know where this is, how to risk stratify your patients. The initial PESI score is pretty complex. There's a ton of different components to it. You could certainly calculate this, fairly quickly. It uses things like age in the actual year that you get that raw number of cancer, heart failure, chronic lung disease, male sex, heart rate greater than 110, a systolic greater than 100, respiratory rate greater than 30, hypothermia, altered mental status, and a SAT greater than less than 90%, excuse me, and then you risk stratify them and get a 30-day mortality and can sort of extrapolate out where they are in that if they're intermediate or low risk. There's a simplified score that I think I would rely on a little bit more just because it's ease of calculating this quickly while in a busy ED. Someone who's greater than 80 has cancer that's been active or treated in the last 12 months, chronic cardiopulmonary disease, a heart rate greater than 110, a systolic less than 100, and an arterial blood oxygen saturation of less than 90. And if you have, if the patient has one or more of these points, then they automatically go into that intermediate group. They're no longer going to be a low risk PE. And again, this is all to sort of frame the next sort of topics that we're going to be talking about. But from here, it's a pretty hard pivot out of this classification. What I do want to start with kind of today is echocardiography in PE. Specifically the 60-60 sign for acute PE. It's something that I think we talk about a lot, but we don't practice a ton. And so I'm going to talk about how you actually take these measurements and then the data behind it. So the 60-60 sign is an echocardiographic evaluation of RV dysfunction to suggest PE. And it looks at two measurements. It looks at the gradient across the tricuspid valve, how high that pressure gradient from regurgitant flow across the tricuspid valve, and the amount of time it takes the pulmonary artery, the blood going through the pulmonary artery to accelerate. The theory is this: if you have an acute PE or some sort of an outflow obstruction, that pulmonary acceleration time, the amount of time that it takes the blood to get to its maximal velocity, is going to be kind of short. It's pushing against a fixed obstruction. But what it doesn't tell you is the chronicity, if this is something acute or chronic that is happening. So then you go to the pressure gradient against the tricuspid valve. And the theory is that if you have an elevated, if you have a chronic pulmonary hypertension or left-sided heart failure leading to right-sided heart failure, some sort of a chronic outflow, elevated pressure, the RV is going to compensate, and the patient's going to be able to maintain some sort of a pressure gradient against the across the tricuspid valve. If this is acute, the RV just sort of gives out, and so you lose that pressure gradient. So the two measurements that we're looking at, again, the pulmonary acceleration time and the tricuspid pulmonary regurgitant gradient, and the number is 60 for both of them. If they're both less than 60, the assumption, and we'll talk about the data for it. The assumption is that these are likely to be an acute PE. So the first of the two things, the tricuspid jet, I think is a little bit closer to our wheelhouse. If you practice general echo, you're going to take a look in your apical 4 windows and put a color Doppler over the valve to see the area where you're getting that regurgitant jet. From there, you're putting a continuous wave Doppler over it to actually measure the speed of every red blood cell along that line, along your continuous wave Doppler, to see the speed that the blood is going back at. And you can calculate a gradient. The formula is 4v squared in milliseconds, but you also don't have to calculate it. The machine generates this for you if you're doing it with the continuous wave Doppler right here. You'll get a pressure gradient calculated for you right there. So in this particular patient, the tricuspid regurgitant pressure gradient is 70 millimeters of mercury, which is above the 60-60 sign. Also, I have no idea if this is from a PE. This is just an example of a TR jet. The second, the pulmonary acceleration time, is something that we don't do as routinely. It's part of the modified short axis view. So if you're in a parasternal short axis and you fan the probe upwards, that you're looking more towards the patient's head, you're going to see this RV outflow tract view. You have the right atrium, the tricuspid valve, the RVOT, the right ventricle as it sort of wraps around the left ventricle to eject blood towards the pulmonary valve here, and the pulmonary artery. You can even sometimes see this bifurcate the pulmonary artery. This is a good view to get for your patients that you think might have a PE, because you can actually sometimes visualize clot in the PA, which is pretty useful in your diagnosis. But if not, this is the view that you're getting. What you're doing from there is you're putting a pulse wave Doppler gate right in front of the pulmonary valve. In the tricuspid, we're using a continuous wave, and that means that it uses the velocity of every single point on that line and calculates it. We don't want every single velocity on this line, because what you'll get is all the stuff after the valve, which is going to be faster than what's going in before the valve, because it's just gone through a tighter, it's just gone through a smaller radius. So you're putting this gate right in front of the pulmonary valve, and then taking a measurement of the speed at which the red blood cells move through the right before the pulmonary valve. And then calculating the time that it takes, again, to get from baseline to its maximum velocity. So here, this is the beginning as the blood cells are starting to move through the pulmonary valve, and this is the max acceleration, and the echoes will calculate this out for you. So it gives you a pulmonary acceleration time of 114 milliseconds. So again, not specific to a PA patient, but this is how you would be doing your measurements. The other thing you can look at from here is something called early systolic notching. You see the way that this is nice and smooth, that accelerates up and then decelerates down. When in the case of an acute PE, you sometimes see this quick drop where there's a very fast deceleration and sort of reach a new steady state once you've overcome the pressure and try to keep like a basic. Once the RV has overcome the pressure of getting into the resistance of the pulmonary artery, then it hits like a lower velocity here. So this is called early systolic notching, and it's also very suggestive of an acute PE. Again, as a review, it's called the 60-60 sign. What you want to be looking for is a TR gradient less than 60 millimeters of mercury, a pulmonary acceleration time less than 60 milliseconds, and the combination of having both is very specific for an acute PE. And then let's look at the data to sort of back this statement up. So this is the historical context for using the 60-60 sign. And this is a 2016 study. It is a retrospective analysis. It's not what we're going to use to say that this is a good measurement. But it was a retrospective analysis of 511 patients who had a confirmed PE on CTA that were either segmental or larger, so clinically significant, I shouldn't say clinically significant, large PE. And it excluded patients who had symptoms for greater than 14 days or CTEPH, because those folks are moving into a more subacute to chronic outflow obstruction. And it looked at all of these different parameters within 24 hours of admission. The LV and RV diameters in apical 4, a McConnell sign and free wall hypokinesis, TAPSE, tricuspid regurgitant velocity to calculate the TR gradient, D sign, pulmonary acceleration time, 60-60 sign. They looked at aortic valve morphology, they looked at mitral valve morphology, and then RV dysfunction kind of globally as free wall hypokinesis or an RV to LV end diastolic ratio. And then other signs of RV overload that didn't meet the above criteria, like RV enlargement in the apical 4, or distended IVC with diminished IVC collapse or a right heart thrombus. This study found that inter and intra rater reliability was really high. Inter rater reliability was 94% and intra operator reliability was 98%. This group of patients, 3.1% of them were high risk PEs, those what we would call a massive PE. And 96.9 were non-high risk PEs. They found in this retrospective chart review that 100% of high risk PEs had at least one of the three things, either a McConnell sign, a 60-60 sign, or a right heart thrombus. Should have informed the basis for the next studies of how we're going to evaluate 60-60 sign and the others. So this is an article that was published in 2021, and then this was a prospective observational analysis of patients who had suspected PE. The way they did this, and this is in the emergency room, the way they did this is that if a patient was suspected of PE, they got a TTE prior to their CTA, and then compared the two, as you know, the CTA being the gold standard. The RV parameters that were evaluated were the pulmonary acceleration time with early systolic notching, the TR velocity maximal gradient of less than 60 millimeters of mercury, a TAPSE of less than 17, an RVS prime of less than 10. That's maybe not meaningful to the non-echo folks, but it's similar to a TAPSE. It's how well the free wall of the RV moves. An RV to LV end diastolic diameter, and then the 60-60 signs. And then what they did is they risk stratified all of these patients based on the European Society of Cardiology guidelines, which is the guidelines that we talked about, the high, intermediate, intermediate, high, intermediate, low, and low risk patients. The study enrolled 56 patients and 24 of them had confirmed PE. What they found is that the 60-60 sign was 93% specific and 70% sensitive. The RV to LV ratio was 91% sensitive and 75% specific, and early systolic notching was 100% specific for acute PE. When you break these down to look into the high risk, intermediate, and low risk PEs, unsurprisingly, most of these signs were seen in the higher risk PEs, the sicker patients, which is to say that we should expect to see them more in our high risk patients, and these low risk patients who maybe are normotensive and don't have any other signs of RV dysfunction are not necessarily going to have this. But again, we just talked about the fact these are not very sensitive studies. They're specific for PE. The other thing that this study looked at was a mortality, the odds ratio for mortality. 15 of the 24 patients with PE expired, and they found that patients with early systolic notching were 17 times more likely to die, and patients with a 60-60 sign were 8 times more likely to die. And so the overall takeaway, I think, from this article is that all these, again, not very sensitive indicators, the 60-60 sign and the early systolic notching have a pretty strong specificity for both PE and for mortality. And so for your patient who's too sick to go to the scanner, their chest x-ray looks clear, you think that they have a PE, but you don't quite want to pull the trigger on anticoagulation or thrombolytic, whatever your choice is going to be, that this is a reasonable choice for those patients to get better information to sort of back up your decision to, empirically anticoagulate them without that CTA evidence of a PE. The next topic we're going to talk about is thrombolytics for submassive. And I want to reiterate that I think this is like where the crux of our training is applied to in PE. It's pretty straightforward algorithm that the stable PE folks get anticoagulants, the sick as all hell massive PE patients get thrombolytics. It's this middle ground here that we're really training to learn how to manage in a more nuanced way. This is an area where good clinical judgment, backed by an understanding of the literature, should be applied in a really individualized way to your patients. And so to give it a little bit background for this, so we use systemic thrombolytics for stroke and MI. We do this all the time. And part of the theory with using systemic thrombolytics on PE is based in this. So the brain gets around 15% of your cardiac output, your coronary arteries get around 5% of your cardiac output. Barring any intracardiac shunting, 100% of your cardiac output goes to the pulmonary artery. So there's good, reasoning to back up the thought that if TPA works in these other illnesses, that it should work in PE as well. And the other thing that is kind of drawn from these other diseases is that maybe we can even get away with a smaller dose of TPA, and we don't need to put a full systemic 90 or 100 milligram dose into this patient's circulation. The goals of TPA, again, historically are sort of twofold. The one is to prevent that immediate cardiovascular collapse and death. And the second is to prevent pulmonary hypertension, a major cause of morbidity down the line for folks who get who do suffer from PEs. And I'm going to review the 3 studies that sort of inform this decision-making. I'm going to spoil it with the fact that basically nothing has been updated in this in the last 10 years. We talk about the same 2 trials over and over and over, but they are worth talking about because they are the landmark studies that get thrown around maybe inappropriately, that get cited inappropriately, and it's good to know where the data is for these. So the first, not a landmark study that we talk about a lot, but the study that sort of informs the background of this is a 2000 study published by the Society of Vascular Medicine. It was a randomized, non-controlled, non-blinded study. It took 23 patients who had a submassive PE had submassive PE and randomized them either to heparin and thrombolytics, heparin or thrombolytics. And it followed them up over the next 7 years. What they found is that the folks who got thrombolytics overall had lower pulmonary artery pressures. They had lower pulmonary vascular resistance compared to the heparin group. And then they went as far as doing exercise testing on a supine bicycle and found that the folks who had only received heparin had much higher increases in, again, their pulmonary artery pressure and their pulmonary vascular resistance. We're not going to go deep into the weeds in this because this is not a practice-changing article, but this is what informs the article, the next study that we're going to talk about, the Moppet. Oh, sorry, and I tried to put in these PICO things to help us stay a little bit more on topic because I zone out when people talk about research. But this article informs, the next topic that we're going to talk about, the Moppet trial, which is cited all the time. It's one of the two landmark studies about PE care. So this is a 2013 study that was designed to evaluate the use of thrombolytics to prevent pulmonary hypertension. It was a prospective single center RCT that included 121 patients. And they took patients who they decided were moderate PE. They didn't use any hemodynamic indicators. There was no RV dysfunction or hypotension, anything like this. It was solely on the size of the PE that they defined as a greater than 70% thrombus in two or more lobar segmental or main arteries, or a VQ scan that had mismatch in two or more lobes. They used half-dose thrombolytics, based on that sort of aforementioned physiologic basis that 100% of the CO, your cardiac output goes to the pulmonary artery. And because in MI, we use a half dose compared to what a PE or a stroke would generally be getting. Their primary endpoint was pulmonary hypertension and a composite of pulmonary hypertension and recurrent PE at 28 months. The secondary endpoints for this study were mortality, duration of hospital stay, bleeding during the hospitalization, recurrent PE, and the combination of mortality and recurrent PE. Again, they didn't consider RV strain or chemical biomarkers at all. These were measured and are reported somewhere. But again, not part of how they separated out the folks who were included for this. So the study went like this. After folks were diagnosed with a PE, there was an echo that was performed within 2 hours. And then they were randomized and got either TPA or not. Then everyone got another echo, again at 24 to 48 hours. This study was obviously not blinded. People knew if I shouldn't say obviously, the study was not blinded. People knew if they got TPA, the practitioners knew if they got TPA, there was no placebo TPA. But the people who were reading the echo were blinded to the entire study. When they were looking at for pulmonary hypertension, they calculated an estimated pulmonary artery systolic pressure. It was calculated based off of an echo and defined it as an EPASP of greater than or equal to 40. This is not really consistent with the way we would define pulmonary hypertension. Pulmonary hypertension is defined based on the mean pulmonary artery pressure. It was previously 25 millimeters of mercury. Now it's 20 millimeters of mercury in an update in the last couple of years, but they went with systolic greater than or equal to 40. The other sort of significant thing about this study is that they had these, in addition to having the half-dose TPA, they had reduced dose anticoagulation. So for Lovenox, they put a hard cap, even though you were getting the 1 milligram per kilogram Q12, it was a hard cap of 80 milligrams in the initial dose. So if your weight base was above that, you were not receiving weight-based appropriate dose. For heparin, everyone got that 70 unit per kg bolus, like we would do for anyone who were bolusing with heparin. But then the group that got TPA was put on a 10 unit per kg drip, which is not what we would be doing for someone who were full dose anticoagulating. And they put a hard cap on not more than 1,000 units per hour for the first 3 hours when the TPA is thought to be most active, before it was increased up to 18 units per kg per hour, which is our more traditional drip dose. And then all of the heparin, even after the first 3 hours, was infused to a goal PTT of 1.5 to 2 times normal, which is what we would call subtherapeutic. That's not consistent with even like our Kings County nomogram. You would not get to the PTT of 60 based on that. The one other thing, which maybe not super important, but for the TPA dosing for patients who are 50 kilos or greater, they got 50 milligrams of TPA, 10 milligrams up front, and then the other 40 over 2 hours. For patients who are less than 50, it was a weight-based dose, 0.5 milligrams per kg, 10 milligrams up front, and then whatever the rest was over 2 hours, which is all this is just to drive down the point that they were very modest in their anticoagulant, both thrombolytic and anticoagulant doses for this study. And what they found from this is they found a statistically significant reduction in pulmonary hypertension, as well as the composite of pulmonary hypertension and recurrent PE at 2.5 years. Where did I go with this? And despite the fact that there was no overall mortality benefit, there was a statistically significant decrease in the composite mortality and recurrent PE, as well as hospital stay. One of the things that's kind of suspicious about this paper is that not one person had a bleeding incident. Lovenox carries around like a 1% risk of bleeding and heparin around a 2% risk of bleeding. So the fact that no one in either study arm bled is a little suspicious that they weren't really ever full dose anticoagulated. There are a lot of other criticisms about this study. The first is that it was a small study, 121 patients. They didn't disclose their funding at all. It wasn't blinded, which we discussed early. When you retrospectively look through, when you look back through the data of who was included in the study, only around 20% of the patients actually had RV dysfunction. Had RV enlargement, and only 6% had RV dysfunction. The biggest sort of glaring issue with this is that it doesn't use anyone's definition of how we measure PEs. You would just be looking at the radiographic size of the PE and not taking into consideration the hemodynamic parameters for these patients. It doesn't use an agreed upon definition of pulmonary hypertension. And again, the fact that no one bled is a really suspicious thing, which they note right at the outset or in their own discussion, that keeping them at a reduced rate heparin is maybe why they had fewer bleeding events. So again, this is a landmark study that gets brought up all the time for the use of half-dose TPA. But I think our takeaway from this is that it may potentially, possibly, if you really want to look at this through a really abstract lens, decrease the risk of pulmonary hypertension. But this study definitely doesn't prove that. And so if people try to cite Moffitt, this is things that you should be keeping in mind about why this half-dose TPA maybe isn't so fleshed out, and that it really doesn't have the data to back it up for preventing pulmonary hypertension. That's in contrast to the PITHO trial, which is the other landmark study. It was published a year later. Oh man, it says submissive. I can't tell you the amount of time that submassive got corrected to submissive in this, and I missed this one. So this is the second landmark study. This was published in the New England Journal of Medicine in 2014. This was a multi-center, double-blind randomized control trial that included 1,006 patients, and it compared tenecteplase with heparin to placebo with heparin in intermediate risk PEs, the submassive PEs. They didn't flesh out the high and low risk at the outset. The primary outcome was death or hemodynamic compensation or collapse within 7 days after randomization, a good patient-centered goal. Safety outcomes included extracranial bleeding, ischemic stroke, and hemorrhagic stroke within 7 days after randomization. They had some pre-specified subgroup analyses based on age and sex, greater than or equal to age 75 versus less than age 75. The inclusion criteria for the study were any 18-year-old with a confirmed PE, but symptoms of less than or equal to 15 days, with RV dysfunction on CT or echo, plus myocardial injury on biomarkers. Sorry, I misspoke. That is exactly the intermediate high risk definitions. They had to have both the radiographic and the biochemical markers. The exclusion criteria was hemodynamic collapse on presentation. Someone who came in with a massive PE was excluded. Someone who was pregnant or delivered in the past 30 days was excluded. Someone who had strict contraindications to TPA, or anyone with a systolic blood pressure of greater than 180. And what they used was a weight-based tenecteplase, somewhere between 30 and 50 milligrams. And then for their heparin drip, everyone received heparin for the first 48 hours before being switched to Lovenox, DOAC, whatever. But everyone got heparin in the first 48 hours with a goal PTT of 2 to 2.5 times normal, which is more consistent with how we dose heparin. They did find there was a decrease hemodynamic compromise and death at 7 days, but not a decrease in all-cause mortality at 30 days. That's up here. Oh, there we go. Despite the benefits for TPA, the TPA arm also had an increased risk of extracranial bleeding and stroke. For their pre-specified subgroup analysis, there was no statistical significance to this group, but it does sort of signal maybe where some more of the nuance and where certainly future research should be. There was a general trend towards an improvement in primary outcome, death or hemodynamic collapse in the first 7 days for folks who were less than 75 years old. And it showed a general trend, but again, not statistically significant, of an increased risk of bleeding in patients who were 75 or older. And so the overall takeaway from this study is that thrombolytics probably do decrease the risk of death for your submassive PEs, or I should say, in the first week, death or hemodynamic collapse. But they come at a really high risk of bleeding. And so this is, again, the landmark study that gets cited a lot, but you should take in a very nuanced way when you are thinking about the patient in front of you, their comorbidities, their risk factors for bleeding, what they stand to potentially lose from TPA versus what they do potentially stand to gain. That is the end of my discussion on the submassive PE thrombolytics, because that's actually sort of where the data ends, is around 2014, and there's a lot of society guidelines and thoughts about this we'll talk about a little bit later. We'll talk very briefly about ECMO for massive PE. This is not something that's very well studied. ECMO is, for PE is essentially cardiopulmonary bypass. You're pulling blood out of the venous system, bypassing the heart and lungs, and putting it back into the arterial system. There was this document that was published in 2019 that was just a retrospective chart review to see kind of where we are utilizing it, and how ECMO is just seeing how ECMO is being utilized in the United States. It's from an NIH database that looked at anyone who was diagnosed anyone who got ECMO for a high-risk PE from 2005 to 2013. It included 77,000 hospitalizations for high-risk PE that they defined as either ending up on mechanical ventilation, pressors, or in shock that was not septic shock. There is a general uptrend. During the time, there's a general uptrend in ECMO usage for high-risk PE from 0.07% to 1.1% in 2013. The utilization was overall higher in teaching hospitals in urban centers compared to non-academic centers. And the overall mortality for patients on ECMO was 61%. And despite the fact that, there was a huge uptick in the amount of usage, there was no change in this mortality benefit. It was still around 61% throughout the chart review. But overall, ECMO was associated with a lower mortality in patients with massive PE with an odds ratio of 34%. And as they looked at the chart, they also looked for predictors that someone was going to have bad outcomes on ECMO for PE, things like age, female sex, obesity, CHF, and COPD. So again, this is another topic that we don't have definitive answers on. We just sort of, you should bear in mind for someone who maybe doesn't have a lot of comorbidities that you think can make it to a center for ECMO, considering ECMO for your massive PE patients. Again, I'm going to be making my own decisions really soon. And when the data sort of fails me, I like to look towards the expert consensus guidelines to help with these complex decisions. So in 2021, CHEST, one of the academic bodies for critical care medicine, came out with new updated guidelines for PE. Actually, for all VT, it included DVTs in here. They had 20-something updated statements and guidance statements. I'm going to go through 4 of them that I think are pertinent to our PE patients. So the first is that in most patients with acute PE not associated with hypotension, we recommend against systemically administered thrombolytics. This is the submassives. They're saying we recommend against thrombolytic, and it cites the PITHO trial, specifically that although it may prevent cardiovascular collapse, there's an increase in major bleeding. The second update is that for patients who deteriorate after starting anticoagulant, but have yet to develop hypotension, who have an acceptable bleeding risk, we suggest systemically administered thrombolytic therapy over no such therapy. So the recommendation that if you are giving someone anticoagulants and then they start that death spiral towards massive PE and you're thinking about thrombolytics, you don't have to withhold that just because they've already received anticoagulation. And they define deteriorate in their guidance statement, similar to what we've been talking about, a systolic less than 90, a drop greater than 40 millimeters mercury, cardiac arrest, or the need for pressors. The third update is that in patients with acute PE associated with hypotension who have a high bleeding risk or failed systemic thrombolytics, you've already given thrombolytics to them, or shock that's likely to cause death before you can get thrombolytics on board, you can consider catheter-assisted thrombus removal over no such intervention. So if you have someone who really can't get thrombolytics because either they can't or they already have, you should consider catheter-directed therapies if it is available at your center. It's a weak recommendation on low certainty evidence. And then the fourth update that I wanted to include for us is that in patients with acute PE who are treated with thrombolytics, we suggest systemic over catheter-directed thrombolytics. This is also a weak recommendation with low certainty evidence. But in general, there seems to be a higher certainty of evidence for systemic thrombolytics, the PITHO trial specifically, compared to catheter-directed thrombolytics, your IR-guided thrombolytics. Since their last update, there were a few small prospective trials, but none of them had data to sort of sufficiently give them reason to change the statement. And in addition to chest, similar guidance was issued by the European Society of Cardiology in 2022 and the American Society of Hematology in 2020. Systemic thrombolytics over catheter-directed thrombolytics if the patient can get thrombolytics. So then we will talk about catheter-directed thrombolytics as our next topic. There are a lot of studies on this that don't do a great job comparing catheter-directed thrombolytics to either systemic or anticoagulants. They sort of compare to other catheter-directed, other proprietary, lots of different, IR toys and tools. But there was a meta-analysis published in 2023 of catheter-directed thrombolysis. It included randomized controlled trials, cohort studies, and case studies that compared catheter-directed thrombolysis with systemic thrombolysis or anticoagulation. It included the submassive or massive PE, the high and intermediate risk PEs. And the primary outcome was all-cause in-hospital mortality, intracerebral hemorrhage, and major bleeding. This meta-analysis had, systematic review included 44 studies and a composite 20,006 patients. The results are pretty impressive, is what they'll try to convince you of. They show that CDT, catheter-directed thrombolysis, was associated with a lower risk of death when compared to systemic thrombolysis or anticoagulants. Here. Catheter-directed thrombolysis and anticoagulants both have a lower association of major bleeding compared to systemic thrombolysis. Although it's worth noting that there was a lot of heterogeneity about what was considered major bleeding, and in some of these studies, it actually didn't specify at all what major bleeding meant. It just used the term major bleeding. Maybe more specifically and more importantly, there was a lower, the metric that I think we'd look at for bleeding that's really important is intracerebral hemorrhage. There was a lower association of intracerebral hemorrhage in both catheter-directed thrombolytics and anticoagulants when compared with systemic thrombolytics. But there was no difference in intracranial hemorrhage between catheter-directed thrombolytics and anticoagulation. The authors try to suggest that there's this big mortality benefit compared to systemic thrombolysis or anticoagulation, but that catheter-directed thrombolytics really only carry the same risk of an anticoagulation, which is the standard of care for RPEs. But if you take a look sort of deeper into this study, the systematic review, is that only one of the 44 studies that are included in this was an actual RCT comparing catheter-directed thrombolysis to systemic thrombolysis. And this is it here. This was specifically for high-risk PE. So this is the massive PEs, the hemodynamic collapse. It was 52 patients. It was randomized controlled. It was non-blinded. And they compared catheter-directed thrombolysis to systemic thrombolysis. Their outcomes were clot resolution in a radiographic sense, and major bleeding, which was intracranial hemorrhage, GI bleed, massive hematoma at the puncture site, or anemia requiring transfusions. My impression of this article, without really going so deep through it, was that the outcome of like clot resolution is maybe not the most patient-centered, meaningful metric. It's not how we would measure anyone. We never get, we don't get a CTA to follow up and see how patients do. We look at their quality of life. We look at their exercise tolerance. We look at the development of pulmonary hypertension. And that maybe it's not pertinent at all. The most important finding of all of this was with mortality. There were 7 patients who died in this study, and all 7 of them were from the systemic thrombolysis group. There was a statistically significant difference in mortality, 0% in the catheter-directed thrombolysis compared to 29% in the systemic thrombolysis. So maybe not making a huge case for the meta-analysis overall, but maybe signaling towards the fact that there might be lower risk of mortality associated with catheter-directed as opposed to systemic thrombolysis. The other sort of caveat to the study that I think is worth pointing out is it doesn't really answer the question that we're looking to figure out, the who gets, what do we do for these submassives? I think in general, if you have catheter, if your patient is able to get systemic thrombolytics, we're giving them because it takes a lot more time to get your catheter-directed thrombolytics. It takes there's like a PA catheter placed and it's put over several hours. And it doesn't answer the question that we're trying to figure out, like for these middle ground patients. But again, just something to keep in mind, there's potentially a lower risk of mortality with catheter directed over systemic thrombolytics. And then we'll talk briefly to end out the lecture today with catheter directed embolectomy. There are 4 main types that are utilized, and it matters, I think, very little to the non-operator. I think it matters a lot to the person in IR, but we're never going to dictate which tools they're using. But I think it's just worth knowing what these tools are. So the first one is an ultrasound-assisted thrombectomy. The way it works is the catheter is placed through the clot, and it uses a high-frequency ultrasound to sort of break up the clot and get the thrombolytics into, penetrate the clot a little bit better. There's no benefit of doing this if the patient can't get thrombolytics. It absolutely requires thrombolytics. The second is rheolytic embolectomy. This is a technique that uses pressurized saline to sort of like at the distal port, sort of like macerate the clot. And then there's a more proximal port that aspirates the broken up pieces. The catheters are really pretty big. They require a venous cut down, and they have a ton of adverse effects. They think from some of the split products of breaking down these clots, but it has a significant risk of bradycardia, vasospasm, hypoxia, hemoglobinuria, and renal failure. And so the rheolytic embolectomy has gotten a black box warning from the FDA, although there was just some systematic review that was published in the last 2 months, arguing that maybe this was a little bit hasty. So something you shouldn't see now, but could potentially see again in the future is the rheolytic embolectomy. Rotational embolectomy is a device that goes in and sort of rotates and breaks up clot while continuously aspirating, but doesn't have those same adverse effects as the saline that's breaking it up, for reasons that I'm not quite sure why. And then the suction embolectomy, this is pretty straightforward. There's a ton of different devices for this. It goes in and sucks clot, frequently with the assistance of catheter-directed thrombolytics. Unfortunately, not one of these 4 devices or types of devices have been studied in a randomized controlled trial against systemic thrombolytics or systemic anticoagulation. It relies entirely on case series, retrospective studies, industry funded, look at how these things work sort of studies. There's one study that that's a randomized controlled trial of catheter directed. It's called the Optilice PE study, but what it randomizes is the doses of TPA that's given. And again, doesn't compare it to systemic TPA or anticoagulation. It just looks at the relative doses of catheter directed TPA. Okay. All right, so just to sort of review the things that we talked about today. Sorry, I should have updated these slides. We talked about the classification of echocardiography and PE, thrombolytics for submassive, ECMO, the 2021 chest guidelines, catheter-directed thrombolysis, and catheter-directed embolectomy. And so we'll go back briefly to the questions that I had at the beginning. And I'm going to see if there are any attendings in the room or on the call who want to weigh in with their opinion for someone who's going to be working on her own really soon. who do I qualify based on these studies? Who do I qual IR for? I'll tell you my answers after.
For me, it goes intermediate high, especially because we have all these other devices now. I have down at least to consider. So I'm usually consulting with IR and MICU, right? Ultimately, it's not going to be my patient. In the end, this is a patient that maybe I don't have to rush to systemic thrombolytics. So that's usually the situation that I'm always getting both my intensivist and IR work. The kind of lower intermediate ones, I don't know about IR. A lot of times I'll do it in conjunction with talking with my intensivist and kind of say like, well, is there really a role here since there's less showing strain on them?
Yeah.
I think a harder question is who are you calling IR at 2 a.m. Right?
Yeah.
It's the kind of, I don't think that, as kind of Dr. Hassel mentioned, I don't think there's a downside of getting them involved in a broad spectrum of them, especially if you're admitting any patient you're admitting, definitely anyone getting ICU involved but for like who you're waking them up and saying, I need you to potentially come in and take care of this patient. As you've already pointed out, I don't think there's a hard and fast answer for that. But anybody where I'm thinking about systemic thrombolytics, I think it should be. And I think that's where these PE teams are coming, becoming more and more.
Yeah. That's a great point that I appreciate you bringing up, is that this is such a nuanced thing that the PE response teams are becoming a really big thing because we don't have a clear answer. We don't have clear guidelines. And so you take a group of experts who understand this data intimately and apply it in real time to patients. Yeah, Prana.
The location and extent of the plan, because I feel like sometimes the actual get virus, these classes, the spot of classes are too distal for.
I'm sure that the question was about where the clot is located in regards to catheter directed. I'm sure that that data exists in some of these papers that are like case series about where they're getting them from. There really weren't good prospective analyses, so I'm not sure, but that does seem like a reasonable question of sort of where, does the IR team think they'd be able to actually reach the clot? And so I will say that in sort of my summary answers for these, the patients that I think I'm waking up IR for is a patient who needs thrombolytics but has a contraindication, a patient who failed thrombolytics and is worsening, or the submassive that has like a central PE, to at very least to get their opinion of do they think that they can retrieve this clot, because that's a skilled operator sort of question, but a really thoughtful one. And then the second question we looked at is the best way to manage a submassive PE. So any thoughts from the audience before I give my thought on how to manage these, or thrombolytics, I guess, for submassives?
For me, I've never been convinced on like the half dose thrombolytic. I think even just conceptually, I've always had a hard time kind of saying, well, if we're saying there's a dose that works and we're trying to reduce the dose to prevent the risk, or isn't there a chance for reducing the effectiveness of it? So I think if I'm actually considering giving thrombolytics, I'm giving the full dose for a submassive. Now, am I doing that for all submassives? Right, as you kind of point out, the data is not even great on what the benefit truly is. But at least for me personally, I don't think half dose of a thrombolytic is the best way to.
Yeah, I would say that's one of my takeaways from this too, is that there's really no compelling evidence for half dose. There's like a Turkish study that also is underway that's looking at quarter dose. Curious to see what they have to say about all that, but like none of this has convinced me. You're sort of in for the penny, in for the pound, yeah. I think, because you're giving these medications with the thought that they're clinically deteriorating. They're on the sort of wrong trajectory. And yeah, I think you're pretty compelled to give the full dose. All right. Any comments or thoughts generally before we wrap up? Come on. All right. So I'm going to wrap up today with my take home points. One is that you should be using the 60-60 sign to rule in, but not rule out PEs. Two, when you're thinking about your intermediate risk PE, think about subclassifying them into that higher low risk intermediate, to help understand their disease trajectory, their level of care, and the potential need for thrombolytics down the line. So you can be mentally prepared for that. And you're not thinking about it as they're crashing. Consider the risk benefit profile of your patient before using thrombolytics or submassive PE. What do they stand to gain? What do they stand to lose? And consider ECMO for your massive PE patients. It is a therapy that we don't have all the answers to yet, but it does have the potential to sort of it does physiologically make sense that you're bypassing the two organs that are failing. And I'm interested to see more about it. Yeah.